So we're going to talk about perimenopause and hormone therapy and try to make y'all comfortable with starting/continuing it. I have no disclosures. Tried to keep things as valid and not biased as possible. So this is important from like a GYN standpoint, just because usually these people are presenting to their primary care providers first. And many primary care providers seem uncertain about prescribing estrogen and progesterone. What's the safest method? When can you start it? When do you stop it? I get a lot of patients sent that, like I'm sent here for hormones. So hopefully this will help explain some things. By the end, hopefully you'll identify common perimenopausal symptoms, what people come in and present with, compare estrogen formulations and routes of administration, and apply symptom-driven, not lab value driven recommendations and individualized hormone treatment. So what is perimenopause? It's this phase before menopause, which the definition is still going a year without a period before you get there. And so anywhere from 4 to 10 years prior to that, women start experiencing symptoms. The average age is 47. I do get the patients in their 30s that are concerned about their hormones and whether they're in perimenopause or something's off. So what's happening during this time is there's ovarian signaling instability. You actually get more of a fluctuation in ovarian follicular activity and hormone variability. So it's not just estrogen deficiency, but the hormones are going up and down. So kind of explain it to a patient as it's a roller coaster. They can be low, but they can also be high, and then they get all of these symptoms that fluctuate and drive them crazy. You also get a decline in inhibin B, which increases the FSH level, which I think is probably one of the more common things I see checked. And so that's kind of like used, especially if a patient has a hysterectomy, but if their FSH level is high, to determine whether they're in menopause or not. The problem with perimenopause is it can go up and it can go down. So someone might have an elevated FSH, and then the next 6 months or a year later, it's back in the premenopausal range. And so these fluctuations contribute to the vasomotor symptoms, so hot flashes, night sweats, and then neurological symptoms. So commonly people come in complaining of brain fog. So try to kind of put a diagram of where estrogen receptors are in relation to what symptoms people are experiencing, and it's basically from head to toe. You have estrogen receptors in the brain, breast, uterus, bone, and the vascular system. So changes in these can affect how your vessels function. You get the vasomotor symptoms, like mentioned before, the hot flashes, night sweats. Most commonly in the perimenopausal period, these patients are having menstrual cycle irregularities, so they're potentially shorter cycles or skip cycles. They are still ovulating, so something to keep in mind if somebody comes in complaining of a missed period or regular periods, please get a pregnancy test. And also something to keep in mind for management and medications. Sleep disruption, so people complaining of they can't sleep through the night or have difficulty falling asleep. Anxiety and other mood changes. They haven't had issues with anxiety, depression before, and now suddenly they feel super anxious all the time. And then genitourinary syndrome, vaginal dryness, painful intercourse, recurrent UTIs. They're the patients that come in and feel like they have a UTI all the time. You do multiple urine studies and they come back negative. And we'll talk about how to potentially help this. And then the cognitive complaints of, I just feel so tired all the time. Brain fog, so things are unclear, I can't find the words that I want. So as far as diagnosis in primary care, most of this is going to be based on their symptoms and their menstrual cycle changes. Like I said, rule out pregnancy. Another thing is that I usually check if they haven't had labs or thyroid labs. A lot of these can cross over and affect menstrual cycles as well. And then anemia if they're having super heavy periods. And then consider evaluating for causes of abnormal uterine bleeding. So especially if their periods are fluctuating, do they have fibroids or endometriosis? A lot of these patients are going to need further workups. And so if somebody needs to be worked up and you're ordering an ultrasound or potentially ordering some type of imaging study, you can go ahead and refer them to GYN because there's a good potential that they'll need a biopsy. And then FSH testing, while frequently used, not super helpful and not routinely recommended just because it can vary so much. So what do we do with these patients that come in complaining of these symptoms? I feel like most of the times in medicine you start with lifestyle modifications, so diet and exercise, sleep hygiene, decreasing alcohol consumption, limiting caffeine consumption. Those can all help with symptoms. Over-the-counter supplements, a lot of patients want to start, they either come in and want to start with those because they want to avoid prescription medication or are scared of hormones. But black cohosh, ashwagandha, berberine, and inositol is probably one of my new favorite supplements because it can help with some of the menstrual cycle irregularities. It can also help with the insulin resistance component. So for somebody that doesn't necessarily need metformin but still has some of those metabolic issues, it's a good option. Vaginal moisturizers that are non-hormonal that are sold over the counter. There are several that I kind of explain it to patients as they have similar things like hyaluronic acid, so same thing that women are putting on their face. Basically now they're vaginal creams and kind of help with in the same manner. Then you have your non-hormonal prescription, so for somebody that's having hot flashes or night sweats or the anxiety, depression component of things, you can start them on a SSRI or SNRI. I feel like patients still have concern about being on these medications sometimes and are reluctant to use those. Gabapentin can sometimes help with hot flashes, not so much in most of the studies. And then we have these newer medications that are the neurokinin receptor antagonists. And we'll talk about those a little bit more in a second. And then we get down to the hormonal medications. So localized treatment with vaginal estrone, progesterone, or DHEA, and then systemic hormone replacement. And still for these women, because they're still ovulating, birth control is still a very reasonable option. Either birth control pills, IUDs, or vaginal rings. So again, treating the symptoms, not lab values, match your hormone of choice or medication of choice to their symptoms. Well, I'll just talk about the neurokinin receptor antagonist real quickly. Selective neurokinin 3 receptor antagonists directly block neurokinin B, and then now there's a new one out that is a neurokinin 1 and neurokinin 3 receptor antagonist. So with these medications, the KNDY neurons in the hypothalamus are traditionally inhibited by estrogen and stimulated by neuropeptide neurokinin B. So then when you have a decrease in estrogen, you have unopposed activity of neurokinin B, which affects body temperature regulation. So decreased estrogen, unopposed neurokinin B, you get heightened KNDY neuronal activity, and then this affects the thermoregulatory centers, which triggers the heat dissipation mechanism, so you get vasodilation, sweating, and these medications tend to work really well for people, and they work pretty quickly. And so definitely a good option for patients that don't want hormonal treatment. or only have hot flashes and night sweats. Something to keep in mind with those is that their LFTs need to be monitored. So as far as hormonal management, a lot of it is looking at pros and cons, and talk with patients about that too. It's more of like a risk-benefit for treatment. So with estrogen, it is the most effective, it's the gold standard for vasomotor symptoms. It also improves genitourinary syndrome of menopause, or in these patients that are in the perimenopausal state but may have some vaginal dryness or painful intercourse. And then also prevents bone loss and reduces fracture risk, which is a big component. I see a lot of patients that come in and either their mom or grandma had osteoporosis, osteopenia, and so they seem concerned about preventing that. So it's a great option for them. The things that we talk about is kind of cons or side effects that you want to keep in mind. So if a patient has a uterus, then if you give them estrogen, they must have some form of progesterone, whether that be oral or an IUD. The risk of VT stroke varies by route, dose, and timing. So how close you start this to menopause. So if you're starting it in the perimenopausal period, then obviously that falls within 10 years of menopause. And then also we'll talk a little bit more about which route is the safest. Obviously not appropriate in somebody that's had an estrogen-dependent malignancy or like breast cancer. Progesterone, I said you need it for someone that has a uterus, and so it protects the endometrium when estrogen is used. It also helps improve sleep quality, so the patients that are having trouble falling asleep or staying asleep, it works usually very well for and pretty quickly as well. And then it can also work really well for patients with their irregular bleeding, either decreasing their bleeding or sometimes stopping their bleeding completely, which most people are fairly happy to have happen. It, however, does not treat vasomotor symptoms alone. Sometimes people have side effects of mood changes that are negative. Bloating or breast tenderness are frequently seen. And I'd say one of the more common reasons that people either want to stop them or stop taking progesterone is they don't like the bloating or breast pain that they have. Breast cancer risk may vary by the type and duration, and so this in the old Women's Health Initiative study, I think didn't get pointed out really well at the beginning that estrogen wasn't actually huge increased risk of breast cancer, but estrogen and progesterone together was a slight increased risk in breast cancer. Now going back and looking at that, even if women had breast cancer or slightly higher risk of having it, their mortality and morbidity actually was improved if they were on hormones. So most people end up on combined estrogen-progesterone therapy, which resolves their symptoms. And so there's a slight increased risk of breast cancer when you use both together. The progesterone helps with endometrial protection. And then there's a lot of different regimens you can do, combinations that are out there to individualize therapy. So then we have to think about which type of estrogen we use. There are 4 types in the body. E1 estrone is weaker. It's more common after menopause. We don't typically check the various types of estrogen levels. We're often checking estradiol, which E2 is your primary systemic estrogen. It's the strongest. It's dominant during reproductive years. So this is typically what we're replacing to make you feel more kind of back to your normal self. E3 estriol is the weakest. It's important in pregnancy. It has good local effect. We don't use it that frequently, but there are some formulations that you can use or get it in vaginal estrogen therapy, and it has minimal systemic absorption. E4 estrol is the fetal estrogen. We aren't usually prescribing it in anything except there is a newer birth control that has it in it and does seem to work well for for patients if they have side effects to other hormonal regimens. Kind of explain it as like your body recognizes it as something that is more natural because it supposedly has seen it before. And then synthetic estrogens, mainly estradiol, so these are what are typically in our birth control regimens or hormone replacement. They do, especially in birth control, pills have a slightly higher thrombotic risk. And then conjugated equine estrogens, which I feel like have kind of decreased in popularity or favor. They're effective but less physiologic. So most of the risk is based on our delivery method. So oral estrogen has the highest risk. It's going through the liver, so you get higher liver conversion, increased clotting, higher clotting risk, then increased risk of stroke and VTE. You also, with oral estrogen, can end up with increasing triglycerides. Conjugated equine estrogens are the next highest risk, and then transdermal estradiol, which we'll talk more about. This is the most favorable for systemic hormone replacement. You're bypassing the liver metabolism. And then vaginal estrogen is the lowest risk as it's mostly localized, minimal systemic absorption, safe with prior clotting history, and even acceptable in former breast cancer patients. Right. So our gold standard for hormone replacement therapy using estradiol is the best thing for hot flashes, bone protection, mood, sleep improvement. It is available as a patch, gel, spray, pill, vaginal ring, and then we all get asked about compounding hormones, which are not going into detail. And this, as we'll focus on what's recommended. The patch is probably the most common item. It's easy. You put it on once or twice a week. There are multiple doses, so typically starting at the lowest dose and then increasing as needed to control symptoms. So when can you absolutely not use estrogen or hormone replacement therapy? If they have active breast cancer, prior estrogen-sensitive breast cancer, untreated endometrial cancer, unprovoked clotting or thrombophilia, active clot, stroke, or MI, or severe liver disease. So what's not on here is a family history of clotting or previous breast cancer that's not estrogen receptor positive are not absolute contraindications, so you can still use those. So then we'll look at our progestin therapy options. So like I said before, if they have a uterus, then they need some type of progesterone. Like the micronized progesterone, it's a capsule. They take it at nighttime. It seems to help with sleep quality. There aren't very many doses. Most people are on 100 milligrams or 200 milligrams, so it's fairly easy. Medroxyprogesterone acetate has a higher risk of breast cancer and cardiovascular risk. We have norethindrone frequently in our birth controls. There's some combined pills that have estradiol and norethindrone in them to be used for hormone replacement. And then levonorgestrel IUDs are great options. They provide the endometrial protection, bleeding control. A lot of people with the higher dose IUDs won't have a period at all. And so for somebody that's having these waves of irregular periods, skipping cycles, and then having heavy bleeding, probably one of the better options to use, and also provides contraception if needed. So if they're, like I said, they're still ovulating, there's still a chance that they can get pregnant during this perimenopausal period. I've had patients that thought they were going through menopause, skipped a period, and then were pregnant. Like I said, micronized progesterone, like the preferred, at least my preferred treatment for if we're doing systemic hormone replacement. It improves sleep. There's a lower risk of breast cancer and clotting versus the medroxyprogesterone acetate. So other things that you'll potentially see or get asked about, progesterone, great option, converts estrogen to testosterone in the vagina, so it's one of the localized treatments. And ospemifene is a selective estrogen receptor modulator. It's an agonist in the vagina and an antagonist in the breast tissue, so also a little bit safer as well. Both of these are FDA approved. The other hormone that I feel like is more and more asked about or requested is testosterone. I'm going to go into a ton of details about that because it is not FDA approved for women. It has only been proven to be effective for decreased libido. Some patients do find it beneficial, but about 50% of patients will not respond at all to testosterone. And so if they ask about it, you can also explain that. So we'll do some cases. So you have a patient, 47-year-old female, comes in with night sweats, new anxiety, sleep fragmentation, still has regular periods, requested labs, maybe her FSH was normal, her estradiol was normal. So what is the most appropriate next step?
Louise, can you advance this?
Oh, sorry, yeah. Are you gonna reassure her because her labs are normal? Start an SSRI because she has this newfound anxiety, now has difficulty sleeping, which could be associated with her anxiety. Provide her transdermal estradiol to help treat some of her symptoms, or offer to repeat her labs in 6 months. Yeah, C. So transdermal estradiol would be a great option for her. Obviously, she's gonna need progesterone because she's having periods, so she still has a uterus, but that is gonna be the best option. And just to point out, these patients that come in and either complain of anxiety or depression symptoms, hormones aren't going to help if they have a long history of anxiety, depression that is there. It's not going to fix everything. But somebody that has all of a sudden just feels more anxious, has never had an issue with it before, a lot of times it will get better with hormone replacement. All right, so our next patient is a 52-year-old with severe hot flashes. She has a history of a provoked DVT after surgery, still has a uterus. What is her safest treatment option? You can give her oral estradiol, transdermal estradiol and progesterone, ethinyl estradiol, or no estrogen with her prior history. Yeah. See, y'all can prescribe this now. So what about the patient with a breast cancer fear? 6-year-old that comes in, she's a breast cancer survivor. She had estrogen receptor positive breast cancer, but she's complaining of severe dyspareunia, recurrent UTIs, not really any systemic symptoms, but just super uncomfortable or the genitourinary symptoms. Yeah, so doing a topical localized estrogen is a great option for her. And just, it comes with an applicator. I usually tell them not to bother with that and just apply a little bit in the vagina because otherwise they end up using the applicator, a ton goes in and it comes back out and then they hate using it. And it's really a great treatment option and kind of underutilized, so helping them know how to use it without it being cumbersome or bothersome is important. All right, so kind of moral of the story, prescribing treatment should be symptom driven, not lab values. Patients definitely come in asking for their labs to be checked. They say that something is off. They know that something is going on. It's my hormones. I just want to get them checked and see where they're at. Not super helpful because the hormones are fluctuating. I try to explain it to them as it's a snapshot in time when you check their hormones. And so they might be normal, they might be abnormal. You check them a week later and it could be the opposite. So not super useful. Sometimes I give in and we can draw them. It's not helpful for me for treating you, but happy to draw them for you also. I don't know if insurance is going to cover them. Some people still want them drawn. So vaginal estrogen, underutilized for GU symptoms. Use it in patients that, between like age 20 and in their 80s. Anyone with any type of vaginal discomfort, as long as it's not from an infection, it really works well for. And so route matters. Transdermal estrogen is preferred just due to the VTE risk. We got to avoid the liver. And it tends to work pretty well because, especially for patients that have any GI related pathology, then it's not going through there. We don't have to worry about how it's getting absorbed. OCP's birth control is okay for these patients. You can really start it. It works really well. If patients are having irregular periods, they can stay on it until they're in, like, if you want to keep them on it, they're doing well, they don't have other medical comorbidities, they could stay on it till they're 55. Get them through menopause, regulates their symptoms, especially the lower dose birth control. Some people won't have a period on it. Pretty minimal risk. One thing we can't promise if we start normal hormone replacement in a patient that's still having their periods is what their periods are going to do with that. So explaining it could make their periods worse, could make them better, could make them go away, but just harder to predict. So birth control is a little bit more predictable for those patients. You want to use the lowest effective dose, reevaluate annually, typically bring these patients back 3 months after starting or do a virtual visit just to ask them how they're doing. Are they having any side effects? Are they tolerating well? Is it working for what they need? Do we need to increase it? Obviously, if they have any side effects, hopefully they will check back in sooner. And sometimes I offer to increase it prior to the 3 months if they feel like it's working, but maybe could be a little bit better when they get past the 1 month mark, and go ahead and increase it to the next dose. So keep in mind your contraindications, so estrogen-dependent cancers, clotting history, and acute or active liver disease. So primary care can manage most of these cases, at least get them started. If they have abnormal uterine bleeding that is requiring imaging or you think might need a biopsy, go ahead and send them over. I probably would wait to start anything. Severe mood disorders, if they have a long psych history, hormones aren't going to fix that. And they also probably need an alternative specialist. And then complex medical histories. So there are some patients that don't really fall into the perfect category or might be kind of borderline on whether it's safe or not to start them. If you don't feel comfortable prescribing it or managing it, then send them our way. And any persistent or worsening symptoms despite treatment. And so this kind of, I feel like more frequently is with the abnormal bleeding. So you start somebody on birth control or something to manage their bleeding, try it, it's not getting better, or it's getting worse, then they probably need further evaluation. So common myths that people see, although getting a little bit better with the new TikTok and social media, estrogen is dangerous. I feel like that typically is the older patients, not necessarily these perimenopausal patients that are on social media. And then lab values must be abnormal. They don't have to, they fluctuate. And you want to treat based on the symptoms. And then even some patients now, thankfully, they've taken off the black box warning, but patients were concerned previously about vaginal estrogen, whether it was safe to use or not. So what hormone replacement is not, and some of this is also a battle against social media, it is not a weight loss therapy. It doesn't replace diet or exercise. So these patients come in and they say that they can't lose weight. They've tried everything and it's not working. It must be their hormones. It may not be their hormones. I kind of explained it to them as like it can help counteract, if we give them estrogen, it counteracts that component of things, but there still are other ways that they need to address this issue. It's not primary cardiovascular prevention. However, it does, estrogen does affect the vascularity, and so you can actually sometimes see decreased blood pressure as it rises. The vessel, like as your estrogen decreases, the vessels stiffen some, and so that does help. You don't want to start a patient with severely elevated blood pressure on hormone replacement, but starting some of these younger patients that are having other symptoms can potentially help with that. And it is not a fountain of youth. Like if you come in, you're not going to and start hormone replacement, you are not going to feel 20 years younger. It's not a magic pill. And it is not necessarily lifelong by default. So patients will come in and ask, like how long do they have to be on this if they start it? They can be on it for 3 months, they can hate it, they can stop it, they can do it for several years, or if they have no risk factors, they can continue it. It used to be stop it at 65, and there now really isn't great evidence supporting that reasoning, and so it's more of a shared decision making. Reassess their symptoms. Do they still need it? Are they on the lowest dose that can manage their symptoms? And then I feel like for me with patients, quality of life is a big thing that I discuss with them. So there are some obviously risk with hormone replacement, but some of these patients are willing to accept that because they are miserable and can't function. They aren't sleeping. Some of them are angry or worried that they're going to kill their family members. And so we just need to make them happy again. So it's worth the risk in those cases. There's a lot of resources between ACOG and the Menopause Society that are not social media related. Questions? Yeah.
One question about that last case study with the cancer survivor. I'm a little leery about using vaginal estrogen because I'm afraid that, or maybe this is a myth, that it could cause problems with your ovaries. Could kind of feed an ovarian cancer. Is that true or false? If they've got a...
I would say false. So that patient was I guess, breast cancer survivor, but the systemic absorption of it is so minimal that it doesn't really affect those things. But also, if you're worried that they have something going on, you're ordering other testing for that. But it's not that you use vaginal estrogen and then they have an ovarian cancer, or the likelihood of ovarian cancer in the general population is less than 2%. So the chance of you using vaginal estrogen and it causing something to grow is pretty minimal.
But if you have a positive BRCA1, and you have an aggressive breast cancer, the chance of metastasis is, equally. I'm not a cancer specialist, but
Yeah.
I'm just thinking,
For those patients, it depends on whether they're estrogen receptor positive or not, because some of them are hormone receptor negative, and so it wouldn't matter at all. If you did, I'd be hesitant to do systemic hormone replacement in them, but just for the vaginal estrogen, that's pretty safe. I also will sometimes tell them to confirm with if they have a history of that, they're usually seeing breast cancer or the breast clinic. But they'll even start people on vaginal estrogen because they can't really do the systemic hormone replacement a lot of times.
Okay, next.
A couple things. One is for our primary care people. The WHI study was not progesterone. It was progestins.
Yeah.
And it's exceedingly rare for a menopausal patient or perimenopause to be on progesterone.
Yeah.
They're all on progestins, which is a little bit different.
Yeah.
Second of all, Dr. McCary, our FDA commissioner, recently gave a talk about the black box warnings. And one of the things he said is that the relative risk of cardiovascular disease in women on estrogens is 0.3. It's the major preventative. Yeah. Where is the evidence-based data for that? I've never seen it. It doesn't exist. And that has been one of the, seeing patients now in the clinic, that's one of the things they're asking for is, give me this because it'll protect my heart.
Yeah.
The data does not support that at all, yet here's our national, quote, authority. Although I do agree with removing the black box.
Yeah.
And as related to your colleague, there's published data that the absorption of Vagifem, which is synthetic estrogen in the vagina, is about 0.2%. So it's exceedingly rare. And there's not a documented case related to recurrence of breast carcinoma. And same with pregnancy. Having published on pregnancy and breast cancer, termination of pregnancy is not appropriate for breast cancer because the outcome is exactly the same, whether they, deliver or not deliver, whatever. I mean, that's patient choice, but not medically indicated. But overall, excellent, because this is, perimenopause is a real, as you know, I mean, and the complaints are so vast.
Yeah.
I mean, it's not just sleeping. And
Everything gets blamed on it.
It's amazing, the amount of complaints, and they're justified. If the patient believes it, it's absolutely true. Very nicely done. Thank you.
Thanks.
All right. Hey, thank you for chatting. I have heard a little more recently about the use of vaginal estrogen to help prevent UTIs. Do you have any insight about the data behind that, or how quality of data behind it?
So it in a way helps prevent it, but it also, patients come in and have that irritating sensation and they think they have a UTI. So it helps, the vaginal estrogen helps with the elasticity in the tissue. If somebody has recurrent UTIs, instead of just using it at the bottom of the vagina or putting it in there, they can put some near the urethra, and it helps with that tissue, not necessarily form a barrier, but in a way keep that area healthy. But I feel like I use it more in the patient that has either urinary symptoms or irritation, and typically it takes care of that pretty quickly.
I was going to say, clinically, I've never used it just for UTI prevention,
Yeah.
but usually they go hand in hand. So
Yeah. I've seen urology use it. They prescribe it frequently for those patients or that have any, even urinary incontinence. Some patients will use it and they run out or they stop using it and then they have issues again. So overall, it just kind of helps strengthen that tissue down there.
How long we can keep patients safely on systemic hormonal replacement therapy? Like, I'm getting 80-year-old patients who are still on hormones. Should I wean them off, or what to do?
That comes, I feel like the quality of life part comes into those patients. There isn't great, we just don't have enough studies to say what point. If they started within 10 years of menopause, that's really when you get the safest, kind of the biggest benefit out of it with limited risk. Definitely have patients that are in their 70s and they want hormone replacement. You tell them that they're at more increased risk for having problems. But if somebody is miserable when they don't have it, I've had patients stop it and then 3 months later they come back and they're like, no, I want to go back on it, and I just document the risk of it. But some of those patients, if primary care providers are uncomfortable, with a 70 or 80-year-old patient being on hormone replacement, then you can send them over.
We have a question over here.
Sorry, I have two questions. The first one is, I have a lot of patients ask me about estrogen for osteoporosis prevention, so I was curious your thoughts on that.
Yeah.
The other question is, what is your threshold for working up abnormal bleeding, since perimenopausal women are having irregularities kind of as part of their symptoms?
So for the osteoporosis part, hormone replacement is not a treatment for it, but it has been shown to decrease the risk of bone loss and fractures, and so I think that's a reasonable request or option, especially in somebody that has a family history of osteoporosis, or a lower weight patient, somebody that's at increased risk for bone loss, or somebody with a prior fracture, and still kind of discuss the other preventative measures, making sure they have enough vitamin D, calcium, and weight-bearing exercises. But I think it is a reasonable request. And then as far as abnormal bleeding workup, so if they're over 35 and you try treating them with something, it doesn't work or it's getting worse, then they should theoretically be worked up. If you treat them with something and it gets better, you give them birth control and it regulates their cycles, then that's fine. Also, patients that are morbidly obese, because they're going to have a higher risk of endometrial cancer, have a lower threshold of getting an ultrasound evaluating their lining. It's hard when they're premenopausal because their lining's going to fluctuate if they're having that bleeding. I feel like if they're over 35 with abnormal bleeding, especially if they're overweight, then have a pretty low threshold for doing an endometrial biopsy.
Okay, Stephanie has
Okay.
a question.
I would love to hear your thoughts on compounded hormone therapy. It's a very popular subject.
Yeah. It obviously is like not FDA regulated. It's not the recommendation from ACOG or from like the Menopause Society. That being said, I have a ton of patients that are on it and they like it. It's adjustable, but I explained to them that, you know, that's a compound that a human is mixing powder with something. There's a lot more room for error in it. Those patients I do follow lab values on, just because I've had multiple patients that have been on more of the compounded therapy. They switch pharmacies and all of a sudden their lab values are like abnormal. It tends to be the testosterone because it's hard to get, it's not going to be covered by insurance either way. But some of them come in and say, like, you know, they want the more natural option. Kind of in my head, like, it wasn't in your body, so it's not natural either way. But if you insist, I explained to them that, like, my recommendation would be to start with an estrogen, like estradiol patch and like oral progesterone. But some of them are dead set on that, and I'd rather monitor them and make sure that things stay okay. I do feel like I've had more patients that were either on compounds or we don't do pellets, but there are plenty of clinics around Charleston or Mount Pleasant that do. And on those that have come in with abnormal bleeding that has ultimately been problematic, either like precancer, cancer, or had like breast cancer from those, because it's